Hello everyone. Today I am going to cover the head-to-toe examination in newborn. So we have to start the head-to-toe examination in cephalocaudal direction. So first we have to examine the head. In head we have to see the head size, shape, fontanelles, suture, scalp swelling is present or not, any lesions over the scalp. So in head size, we have to measure the head circumference and we have to see according to gestation age, baby is having the normal head size or any abnormal. We label the microcephaly whenever head circumference less than -3 standard deviation, as you can see in this image, and macrocephaly whenever head circumference more than 2 standard deviation. Here in this image you can see baby is having hydrocephalus and macrocephaly is there. Then see the head shape. Is it the normal shape or having any abnormal head shape? Example, because of craniosynostosis, because of premature fusion of the cranial suture, baby developed the abnormal shape of head. So either dolichocephaly or brachycephaly or plagiocephaly or trigonocephaly, we have to differentiate. And here in this image you can see baby is having the abnormal shape due to hydrocephalus. Now see the frontal bone. So frontal bone is normal slant and normal prominence of the frontal bone or any abnormality is there. Example, here you can see because of hydrocephalus having the prominent frontal bone. Also in this image you can see prominent frontal bone is present because of hydrocephalus. Now we have to palpate the fontanelles. So in newborn, anterior and posterior fontanelles should be palpated. Anterior fontanelle is present at the junction of two parietal and two frontal bone. Here in this image you can see this is the anterior fontanelle margins. Here it is already drawn between two parietal and two frontal bone. Normal size at birth in full-term baby 2.5 into 2.5 centimeter. In shape is rhomboid or we can say diamond shape. It is open, soft and flat. It closes between 9 to 18 months of life. Whenever there is a large size fontanelle, then we have to suspect either baby is having hypothyroidism or trisomy 9, 13, 18, 21, and also in IUGR babies or those who are having the rickets, hypophosphatemia, osteogenesis imperfecta, achondroplasia, cleidocranial dysostosis, all will lead to the large size fontanelle. A small size fontanelle seen secondary to brain growth retardation, craniosynostosis, and also in hyperthyroidism. Then we have to measure the anterior fontanelle size also. So in this image you can see there are two methods. One between end to end. Here you can see we can take the horizontal length and vertical length. So AB and CD. Then we have to multiply. So it is 2.5 into 2.5 centimeter at birth. Or we can take the midpoint of the border. So in this method you can see we can take the midpoint. So AB and CD again we have to multiply. So by these two methods we can measure the size of anterior fontanelle. Auscultation of anterior fontanelle should be done for the cranial bruit. If it is present, then it may be because of referred sound from the heart or AV malformation in the brain. Posterior fontanelle is present at the junction of two parietal and occipital bone. Normal size at birth 0.5 cm in full-term newborn baby. And shape is triangular shape. It closes at 1.5 months of age. Now for the palpation of anterior fontanelle, we have to keep the three finger you can see in this video, and we have to see the pulsation which is visible in the anterior fontanelle. Now for the posterior fontanelle, we can palpate by the our tip of our finger between occipital and parietal bone. Then we have to palpate all the sutures of the head: sagittal, coronal, metopic, lambdoid. So here in this video you can see I'm palpating all the sutures. So to rule out is it the normal suture lines or baby is having the early fusion of suture because of craniosynostosis or wide separated sutures which is seen in hydrocephalus, because early intervention is required in both craniosynostosis and hydrocephalus for the proper brain growth and development. Then palpate the scalp for any swelling and see if swelling is present. Is it the caput succedaneum or cephalohematoma or subgaleal hemorrhage, or sometime in the forceps delivery baby will have the some injury marks. So the basic difference between these three swelling: caput present at the time of birth, it is subcutaneous swelling. It is because of increased intrauterine pressure on the head during the labor time. This swelling is soft, boggy and fluctuant and pitting edema, and it also crosses the midline as it is present above the cranial suture line superior to the periosteum, so it crosses the midline suture line. It typically resolves spontaneously within 72 hours of birth. Here you can see this is caput succedaneum. While the cephalohematoma, it is subperiosteal bleeding due to injury of blood vessels, and it is firm and fluctuant swelling. It is not crossing the midline as it is present inferior to the periosteum, and it is resolved between 2 weeks to 6 months of life. Generally, it takes 1 month to be resolved, and there is an increased risk of anemia, jaundice, and sepsis, and commonly seen with the forceps and vacuum extraction. Subgaleal hemorrhage, in which blood is collected between epicranial aponeurosis and periosteum. It also crosses the suture line, but this swelling is more diffuse and it can even enlarge further and may shift with the movements. And serial monitoring is required, and hematocrit should be measured serially because it can lead to the hemorrhagic shock also. It is generally seen in vacuum extraction. By this image you can understand the scalp swelling. These are the layer of scalp. First is the skin layer. Below the skin, this is the subcutaneous space. Below this it is epicranial aponeurosis, and this is periosteum dotted line. This is the skull bone, and this is a periosteum, and this is dura, and this is the brain tissue. Whenever at the time of birth, because of the pressure on the fetal head during the delivery process, serosanguinous fluid is collected in the subcutaneous space. It will lead to the swelling, and it is known as caput succedaneum. It is crossing the midline, present at the time of birth, generally resolved by 72 hours of life. No complication occur because of caput succedaneum. Now, because of the trauma at the time of delivery, bleeding can occur in the subperiosteal space between the skull bone and periosteum, and this swelling resolve by few weeks to few months after birth. It generally take the 1 to 2 months, and this swelling is not crossing the midline. And we have to counsel the parents also, because this swelling takes the few weeks to few months after birth to be resolved, and this can lead to the exaggerated jaundice, and also sometimes anemia can occur because of cephalohematoma. Sometimes because of the trauma at the time of birth, emissary veins are ruptured in the subgaleal space. It leads to the subgaleal hemorrhage. This swelling present between epicranial aponeurosis and periosteum. This is huge swelling compared to the caput and cephalohematoma. and this swelling can lead to the life-threatening complications also. Example, patient can develop the hypovolemic shock or sometimes severe anemia. So close monitoring is required. This is suggesting epidural hematoma. It is a rare in neonate except whenever there is a neonatal head injury occur, which is very rare, and this is between the outer layer of dura and skull bone. So you have to remember all the scalp swelling and you have to examine the newborn to see any scalp swelling is present or not. Here in this image you can see this is the bogey swelling crossing the midline present at the time of birth. It is caput succedaneum. This swelling is also similar caput succedaneum. Here in this image you can see the swelling which is not crossing the midline form. It is cephale hematoma. Now here you can see other than this swelling we have to see any other swelling is present over the scalp. So this swelling is encephalocele present over the occipital bone, and this baby is having anencephaly. So we have to mention whenever we are doing the head to toe examination if any abnormal finding is there. Here also you can see this is also the encephalocele. It is the sac-like protrusion of the brain through the opening in the midline of the skull from the occipital bone. Now see, baby is having normal scalp or any lesion is present. So here you can see these are the lesions present at the time of birth. It is aplasia cutis congenita, and later on when it heals become like this. It is a rare congenital skin defect characterized by the focal or extensive absence of epidermis, dermis, or sometimes subcutaneous tissue can also be absent. Here also this is another child having the similar presentation. Now after the head examination, face should be examined to see the face is normal, symmetrical, or baby is having any asymmetrical face or any characteristic face or any skin lesions over the face present. So here in this video you can see baby is having the asymmetrical face. Here in this image also you can see baby is having the asymmetrical face because of hypoplasia of depressor angularis or its muscle. I have already explained in one of my video. Here you can see baby is having the lesions, skin lesions over the cheek. This is atopic dermatitis, and details of atopic dermatitis I have already explained in one of my video. Then see any characteristic faces are present or baby is having the normal facial features. So here in this image you can see baby is having the coarse facial features because of hypothyroidism. Protruded tongue, macroglossia, wide open mouth and coarse facial features are there. Here in this image you can see baby is having the moon-like facies, mongoloid faces seen in Down syndrome. And after head and face, we have to examine the eyes for the eyebrows, eyelashes, eyelids, size of the eyeball, slant of the eyes, conjunctiva, cornea, sclera, intercanthal distance, then pupil, iris, lens and lacrimal gland should be examined. In eyebrows and eyelashes, we have to see the color, texture and density of hair in the eyebrows and eyelashes. So here in this image you can see baby is having the hypopigmented eyebrows and eyelashes which is seen in albinism, and sometimes eyebrows are sparse, example in premature baby and in various syndromes. Then check the eyelids. Edema of eyelids can be the normal finding at the time of birth, especially in phased presentation, which generally resolve after few days. And it can be pathological as seen in the various conditions. Example, congenital nephrotic syndrome if patient is having renal failure, or sometimes conjunctivitis can also lead to the edema, and angioedema or hypothyroidism. So this baby is suffering from hypothyroidism, and here you can see the edema present over here. And this is because of the cellulitis and eye infection, baby is having the eyelid edema. Then check the eyelids for the coloboma also. Upper eyelid coloboma seen in golden hour syndrome, and lower eyelid coloboma example seen in Treacher-Collins syndrome. Then size of eyeball. Is it normal or any abnormal eyeball size? Example, prominent eyeball known as exophthalmos. Here in this image you can see baby is having prominent eyeballs. Shrunken known as inophthalmos. Small size of eyeball microphthalmos, and enlarged size known as buphthalmos. Then check the slant of the eyes. Is it the normal slant or having the mongoloid slant? Example, here in this image you can see baby is suffering from Down syndrome and having the mongoloid slant. So inner canthus is lower than the outer canthus, while the antimongoloid slant, here in this image you can see where the inner canthus is at upper level compared to the lower canthus, seen in Turner, Nooner's, Treacher-Collins syndrome. Then check the conjunctiva for any hemorrhage, which is a common finding in newborn. Then for the conjunctivitis, any watery or yellowish discharge from the eyes. Then palpable conjunctiva for the pallor we have to examine. So bulbar and palpable, both the conjunctiva we should examine. Then check the cornea. We label the microcornea whenever size is less than 10 mm, and megalocornea whenever size more than 13 mm. So normal size is between 10 to 12 mm, and corneal size more than 1 centimeter can be seen in congenital glaucoma also. And see any keratitis or corneal ulcer or clouding of cornea. So here you can see the corneal clouding is present. Then check the sclera for the yellow discoloration, and blue sclera can be seen in Marfan, osteogenesis imperfecta, and Ehlers-Danlos syndrome. So we have to check the sclera for the any discoloration. Then we have to measure the intercanthal distance. It is the distance between both the medial canthus of eyes. If it is equal to the one eye width, we label as a normal. If it is more than one eye width, then it can be hypertelorism or telecanthus. In hypertelorism, interpupillary distance is also increased. So we have to take first midpoint of both the pupil, then we have to measure the distance between this. It is known as interpupillary distance. So if interpupillary distance and intercanthal distance both are increased, we label as a hypertelorism. When the interpupillary distance is normal while the intercanthal distance is increased, we label the telecanthus. In hypotelorism, distance between medial canthus of both eyes less than one eye width. So to take the eye width, just we have to measure the horizontal distance between medial and lateral canthus. Now we have to check the lacrimal gland. Here in this image you can see child is having the swelling of the lacrimal gland. It is mucocele dacryocystocele. Here in both the eyes baby is having the lacrimal gland swelling. It is bilateral mucocele. Then examine the nose for its shape, position. Check the nasal bridge, nasal septum, columella nasal, ali nasal, nares and nasal cavity. In nose examination, we should insert the nasogastric feeding tube in both the nasal cavity to rule out the choanal atresia. If baby is having bilateral choanal atresia, then baby will become symptomatic having the central cyanosis with the respiratory distress. and this cyanosis resolved during crying. While in the cyanotic congenital heart disease, patient will have the exaggerated or worsened cyanosis during the crying. So we can clinically also differentiate. This condition requires the urgent intervention. Now after nose we have to examine the mouth. We have to check the any abnormal finding in lips, philtrum, gums. We have to check for any congenital or neonatal teeth. You can see in this image. Check the palate for any lesion or cleft. Tongue normal in shape and position or not. Tonsil, uvula, pharyngeal wall and symmetry of mouth should be checked. Here you can see baby is having asymmetrical face. Here in this image you can see baby is having the coarse facial features with the open wide mouth and large protruded tongue. It is macroglossia seen in congenital hypothyroidism. Here in this image you can see baby is having the congenital or neonatal teeth. Normally do not require any treatment except when there is a risk of aspiration because of the teeth is loose, then we have to remove it. Then check the palate and lip. Here you can see baby is having the bilateral cleft lip, and here you can see cleft palate is present. So always examine the palate and lip to rule out the cleft palate and lip. Here in this image you can see baby is having the white patches over the tongue and also over the oral mucosa. This is because of fungal infection Candida albicans, labeled as a neonatal thrush or oral thrush. After oral cavity, we have to examine the ear for its size, shape, position and symmetry, and also we have to check the external auditory canal and tympanic membrane. If any deformity is there, then we have to mention example large prominent ear seen in Marfan and Fragile X syndrome, deformed pinna seen in example in Treacher-Collins syndrome. This child is having the deformed pinna, microtia is present. Low set ear can be seen in Downs and Turner syndrome. We have to draw the horizontal line from the outer canthus. If ear is present below this line, then we will label as a low set ear. Normally 1/3 should be above this line and 2/3 below this. Here in both the images you can see this is ear tape. It is preauricular skin tape present in various syndromes, example Turner, golden hair. This baby was diagnosed with the Turner syndrome. The neck should be examined for symmetry, mass or any swelling or having thyroglossal duct or brachial cleft or pit or any webbing or short neck. Here in this image you can see baby is having the swelling in the neck. It is because of sternocleidomastoid tumor. And here also you can see this is cystic swelling from the neck. It is ruptured cystic hygroma. After that we have to examine the clavicle for symmetry. Any asymmetry is present bilaterally, then see any swelling over there, and crepitus. Whenever there is a fracture, clavicular fracture due to the trauma at the time of delivery, which is very common in the breech delivery and forceps and vacuum delivery. So we have to examine the clavicle for any fracture. After that we have to examine the chest to see the shape of chest. Sometimes newborn is having the pectus excavatum or carinatum. See the symmetry. Any asymmetry is there because of the example absence of pectoralis muscle congenitally. Patient may have the asymmetry. Then see the position of nipple bilaterally at the same level and any accessory nipple is there or not, and check the swelling of the breast. Sometime newborn is having the swelling of the breast. Here in this image you can see it is mastitis neonatorum. Then check for any dilated vein, scar or sinus. Here you can see the baby is having the lesions over the chest area. Then check the abdomen for its shape of the abdomen normal or having a scaphoid or distended. Then check the umbilicus, its position and its shape, is it the normal or protruded or having inverted umbilicus? Then check for any engorged vein. Here in this image you can see engorged vein are present, and here in this image you can see baby is having the umbilical hernia. Then check for any scar, sinus, mass or any hernia. Then examine the abdomen for umbilical cord and umbilical cord clamp. Normally, umbilical cord contain two arteries and one vein. And what is the basic difference between artery and vein? Here in this image you can see these two are the arteries. Arteries are thick-walled, small lumen structure and just like a protruded structure, while the vein is thin lumen, collapsed and larger lumen structure. Whenever you are inserting the umbilical venous catheter, you have to identify the vein, then you have to insert. And normally, umbilical vein positioned at 12 o'clock position. So here you can see these two are the arteries and one is vein. Whenever there is a single umbilical artery, then you have to examine the baby for any congenital malformation or any syndrome. Sometimes newborn is having congenital anterior abdominal wall defect. In this image you can see newborn is having the omphalocele at the level of umbilicus, bowel loops, liver and sometimes spleen also herniated, and it is covered with the sac and associated with the other congenital malformation. This is gastroschisis. It is present in the right-sided paraumbilical area, not covered with the sac, and in this umbilical cord is intact. And this is really associated with the other congenital malformations. Here in this image you can see this is umbilical hernia. Protruded umbilicus is present. Whenever it is present in newborn period, rule out the hypothyroidism and also the any congenital malformation. If the baby is healthy and having the umbilical hernia, then we have to counsel that this hernia size will increase up to 6 months of age. Then it will slowly regress by the age of 2 years in 90% children. So surgery is not required except in few cases where the complications occur. Example, if the baby is having intestinal obstruction due to the strangulated hernia or having the constipation with abdominal distension with excessive crying. So we have to counsel the parents. This is soft red pink color lump present over the umbilicus and also a small amount of the fluid secrete from this lump. It is umbilical granuloma. In this topical application of silver nitrate or sometimes topical steroid can be applied. Single application of silver nitrate is also effective, and if it is not disappear by this treatment, then surgery can be done. After abdomen, back and spine should be examined for its symmetry, any visible pigmentation, hair tuft, pit or sinus tract which suggests the patient may be having the spina bifida, or any visible mass or swelling which suggests patient is having the either neural tube defect or any other mass. So here in this image you can see this is hair tuft over the sacral area, and here you can see the swelling present over the sacral region. So these two are the images of spina bifida aperta. Here you can see this is meningomyelocele. Neural tissue is also visible. This is meninges and this is neural tissue. So this is meningomyelocele. These two are the spina bifida occulta. Here the skin covering the swelling, and this is the closed vertebral defect. This hair tuft also suggests patient may be having the spina bifida occulta. Then we have to examine the hips for the congenital hip dysplasia DDH, because it is also common. For this we have to check the gluteal thigh fold symmetry, leg length should be compared. We have to perform the Barlow and Ortolani maneuver. Details of these two tests I will take in separate video. Whenever there is a clunk, dislocation or relocation occur, or asymmetry in the abduction, we should consider these tests to be positive. Then we have to examine the upper limbs to see is it normal or having any congenital malformation. Example, here in this image you can see this is phocomelia. Then see for the single palmar crease. Here you can see single palmar crease is there. Then absent thumb, which is generally seen in Holt-Oram syndrome. Here you can see in this image patient is not having thumb in both the hands. And C4 polydactyly, syndactyly. Here in this image you can see this is post-axial polydactyly. Then examine the lower limb. Is it normal or having any congenital malformation? Then you have to mention. Example, in this image baby is having polydactyly. Here it is club foot, and this is congenital bend or amniotic bend syndrome. And here you can see this is pitting edema present in lower limb. So any abnormal finding you have to mention. Then you have to check the skin for its color, pigmentation, check the texture, any hemorrhagic spot, any rashes. Here in this image you can see it is erythema toxicum. Then any Mongolian blue spot, palmar erythema or erythema toxicum, and this is showing the melia. Details of the skin findings in newborn I have already explained in one of my video on neonatal skin conditions. Then in skin color we have to mention the normal skin color or having the acrocyanosis where the palm and sole are cyanosed while the whole body is pink. Central cyanosis where the lips, tongue, oral mucosa also cyanosed. Pale whenever there is a anemia, yellow whenever there is a neonatal jaundice. So here in both the images you can see baby is suffering from neonatal jaundice. So yellow discoloration of the sole and whole body is yellow discolored. In this video you can see how to examine the newborn for neonatal jaundice. We have to praise the skin and we have to see the color of blanch skin. And this is according to the Kramer's criteria up to what level discoloration is present. So in this newborn you can see the color of blanch skin is yellow over the forehead, chest, abdomen and limbs. And then if bilirubin is more than 15 milligram per dl, then palm sole also yellow discolored. It is always pathological. So in this newborn you can see yellow discoloration is present even over the palm. So it is according to the Kramer's criteria. We have to categorize the severity, and this is also asked in the exam how to examine the newborn for neonatal jaundice. We should not examine the sclera for jaundice in newborn. We should examine the skin discoloration by pressing the skin area, and we have to see the blanch skin color from forehead till the palm sole. Then nails should be examined. Is it normal or having any discoloration, paler, cyanosis or meconium stain? Here you can see these are cyanosed. Then bones and joints should be examined. Normal or any deformity. Here you can see it is club foot present. Then any swelling, symmetry and hip joint should be examined for the DDH. Then lastly, anus and genitals should be examined. Normal or any abnormality is there. Especially we have to rule out the anal atresia if baby is not passing the meconium by 24 hours of life. And also sometime meconium is coming from urethral opening. It is suggesting that patient is having anorectal malformation. So we should rule out imperforated anus or any other anorectal malformation. Also check the for any inguinal hernia, hydrocele, Trojan testis, phimosis, hypospadiasis or clitoris enlargement, which is can be seen in ambiguous genitalia, any vaginal discharge. Here in this video you can see in head to toe examination of the newborn, we have to start the examination from the head. In scalp we have to check the Fontanel suture line, any swelling, then check the eyes, eyebrows, ears, then nose and oral cavity, then neck and clavicle, then chest, abdomen, then umbilical cord, then limbs and palm sole should be examined. And we have to see the skin color, then all the joints of the body should be examined and nails. Then back should be examined. And lastly, after back, we have to examine the genital and anus. Thank you so much. This is head to toe examination of the neonate.